Thank you, Dennis. You're so funny. I appreciate it. All right, so as I mentioned, I am the Director of Research and Strategy at the LGS Foundation, also the Lennox-Gastaut Syndrome Foundation, and I'm a scientist that helps these families that are in the space to raise money and then fund it on research, and also help them understand the clinical trial world and the clinical world, and any number of things as families try to become more and more involved in understanding their disease. And I want to talk a little bit about early life epileptic encephalopathies as a whole. I'll focus mostly on LGS. And I want to talk a little bit about it from a parent standpoint. I am a mother of a now 23-year-old daughter who has LGS, but also from a scientific perspective a little bit. I have a PhD in cellular and molecular neuroscience and have studied these diseases in the lab. Did that for about 15 years before I moved on. So the phrase, let's see if I can get my slideshow to work. The phrase epileptic encephalopathies is used differently by different people, so I just want to be clear about what I'm talking about. I know in this seminar you guys have talked a lot about the epilepsy syndromes or different syndromes, and this term is still used quite a bit in the epilepsy space. This is really electroclinical syndromes that have been described over 100 years of descriptive terminology by clinicians, and they group epilepsy patients based on the type of seizures they have, the age of onset, the history of the disease and how it progresses over time, specific EEG patterns, sometimes genetics, and sometimes response to treatment. And so this is still a useful way of looking at things. The epileptic encephalopathies are very different and unique in that this is a concept where the abnormal electrical activity associated with the epilepsy is actually then leading to further abnormal development of the brain. And so when you start to look at a chart like this where it talks about the ages of which these encephalopathies will appear, and there's a number of them, many you've probably heard of, West syndrome, Ohtahara, Lennox-Gastaut syndrome, of course. These are evolving over time, and so the abnormality may appear and the seizures may appear very early on, but as that abnormal seizure activity continues to persist, it starts to change the brain in ways that are completely abnormal. And so you begin to develop a disorder of the secondary and tertiary brain networks as opposed to just the primary network that was developing. And so this concept that as I refer to for the epileptic encephalopathies isn't necessarily these discrete syndromes, but it's injury syndrome where the seizures themselves then beget further seizures and further delay and further problems in the brain. So what is LGS specifically? From a clinical standpoint, it's defined by an age of onset between 1 and 7 years. It's thought that the brain cannot display the typical EEG features of LGS until it reaches a certain maturity level. So again, LGS is something that happens while you're sitting by watching seizures go from bad to worse. The age of onset is between 1 and 7. There's multiple seizure types. Pretty much any seizure type that exists can be seen in LGS, with tonic seizures being associated with sleep being the most prominent, and probably the closest seizure type that actually is linked to the syndrome. It's in almost all of the cases eventually. The EEG pattern I'll show you in just a minute. It's slow spike and wave, and then also something called paroxysmal fast activity, which is what a tonic seizure looks like on an EEG. Could be caused by any number of things. About half of the cases evolve from infantile spasms or West syndrome into LGS. So again, it evolves over time. It can be caused by malformations of development, it can be caused by tumors, stroke, lack of oxygen at birth. There can be single gene disorders such as SCN2A, SCN1A, CHD2, a number of genes, which I'll talk a little bit about. There are a number of FDA-approved treatments. None of them work. And the prognosis is very, very poor. About 10% of the patients will succumb to death by the time they're in their early 20s. 90% of them will be intellectually disabled at the moderate to severe range, and 80% will continue to have seizures into adulthood. Here's the slow spike and wave that I talked about. This is between seizure EEG on these patients with abnormal slowing. And then here's the paroxysmal fast activity, which is the signature of a tonic seizure often seen in sleep in these kids. So that's the clinical definition of LGS. I want to talk about what it's been like for me and my family. And this was our introduction into LGS. We woke in the middle of the night to my daughter, who was 2 at the time, shaking and gagging. We thought she was choking. We had no idea that she was having a seizure. We called paramedics and we actually told them she was choking. And I remember they arrived and they examined her. It was over by the time they got there. And they said, you know, her airway is clear, but what you described sounds an awful lot like a seizure. She had a couple of more of these now that what we know are generalized tonic-clonic seizures in sleep. And then she went 6 months without having any seizures at all. And we thought we had dodged a bullet. We didn't really even know what seizures were. Even when the paramedic said, hey, we think it's a seizure, we were like, oh, well, what is a seizure? But by the time she was 3 years old, the seizures came back. They came back with a vengeance. Not only did she have generalized tonic-clonic seizures like the one shown here, but they began to develop other types of seizures. She developed myoclonic seizures like you'll see here, where she would a full body jerk, often throwing her face first into the ground. And then also atypical absent seizures, as you can see here, where there's a staring component along with mild motor twitching. By the time Savannah was 17 years old, she had had more than 30,000 seizures. She was seizing every day. She had tried and failed 26 different therapies, and nothing was working to help her. I did, at the time, I was a really young mother. I think I was 23 or so. So I counted her seizures, which is all you could really do. And this is just the number of seizures over this time frame plotted by year. And you can see the roller coaster nature of the graph. And in addition to that, it's not just by year, but if you break this graph down by month or by week, you see the same roller coaster. There was absolutely no predictability to the seizures in LGS. Not only that, my daughter was going into non-convulsive status epilepticus, where the seizures themselves don't remit on their own. They don't stop on their own. And so you have to intervene medically. I do remember life before emergency at-home rescue medicines existed. For example, benzodiazepines can be used now, and there's some nasal and oral versions. But before that, you had to go to the emergency room. And if at-home emergency meds don't work, they will then put these children into a medically induced coma to stop the seizures, and then spend the next several weeks to months bringing them out of that coma if possible. So this was just a graph between 2006 and 2011 of the number of times she was getting at-home emergency rescue meds. And you can see it was increasing over time. So back in 2012, when Savannah was about 16 or 17, I was asked to give a testimony, a very short 3-minute testimony to the Institute of Medicine. And the testimony was about what is it like living with Lennox-Gastaut Syndrome, living with epilepsy. And I want to just briefly share that testimony with you now, because I think it really outlines what our life was like during that time. Again, it's very short. So my daughter, Savannah, was typically developing until the age of 2 when she had her first seizure. The doctors called them episodes, events, and spells, but never seizures. And they began to claim her development. She seized every day from the time that she was 2 years old to the time that she was 18. And this is a snapshot of what our lives look like living with this devastating epilepsy. Medical. The number of seizures that she'd had to date at the time I gave this talk, 27,949. The number of years it took to get a diagnosis of Lennox-Gastaut syndrome, 3. The number of neurologists that we saw during that time before the diagnosis, 7. The number of treatments that she had tried and failed to date, 26, including diets, devices, and therapies. And the cause of her epilepsy, unknown. Financial. The cost of her monthly drug regimen at that time, $1,640. The number of times that she needed emergency medical intervention for her seizures to stop them during that month, 7 times, and the cost per emergency intervention, $183. The number of times she'd been hospitalized, 11, and the cost of our last hospital stay, $53,475. Life. The number of days that she'd been absent that school year, 41 out of 121. The number of years that she had to have an IEP or an individualized education plan since she'd had this disease, 12. And the number of years that I had to fiercely advocate for her to have that individual education plan, 12. And the number of minutes in a day that we could leave her alone, 0. Family. The number of times that week that I had been late to work because of her illness, 2. The number of times my husband and I had been on the brink of divorce because of her illness, 3. And the number of times that I had become clinically depressed and been treated for depression since she got sick, 5. And then there were factors that we can't quantify. The number of times that we had to cancel trips or outings, and not vacations. We didn't go on vacations. We would cancel trips to the grocery store or maybe an occasional birthday party because seizures could strike at any moment. And then there was the amount of time that Savannah would live before epilepsy finally took her life. So what did we need to know back then when she was first started having seizures? Well, we needed a faster diagnosis. We needed to know that she had epilepsy, and we needed doctors to not tiptoe around that diagnosis by calling them spells or events or episodes and not seizures. We needed to know that 1 in 3 people with epilepsy don't respond to any available therapies. We felt so alone in the early years, and there were so many of us that are like that and don't respond. We needed to know that seizures could manifest in different ways. I have hours and hours of seizure video in Savannah of my daughter going through atypical absence seizures and status and not recognizing those as seizures because I thought tonic-clonics were the only thing that I was looking for. I needed to know that we were grieving as we started to lose milestones and lose ground with her. I thought I was going crazy for many years, but really I was just grieving. And I needed a public that understood epilepsy. There's nothing worse than being on the soccer field with your other child and your child goes into a seizure and parents are shielding their kids from your child having the seizure because they are somehow offensive or as if it's contagious. 15 years later, what we need is we needed to know the cause of epilepsy. For so many years, doctors would say, thankfully, we don't need to know the cause of epilepsy in order to treat it. But that just never made any sense to me. We needed help financially. We're drowning in medicals for many, many years. We needed doctors that wouldn't give up on us. There were many that just threw up their hands and said they couldn't help anymore. And we overall just needed help. Not only am I Savannah's mother, but I've had to become her doctor, her advocate, her activist, her pharmacist, her emergency medical technician, her lawyer, so many things. And it's taken over every aspect of our daily lives. That was the testimony I gave, and I think it gives a really nice snapshot. I often talk about families living with epileptic encephalopathies and LGS especially as living in the trenches of being in war. Now, I never served in war. I was in the military. But I do think that it's a very good analogy. These families are just surviving, and they're waiting for the next attack by seizures. When Savannah first got sick, as I said, I was a really young mother, and I began to learn everything I could about epilepsy. This was back when you had to check out internet time at the library for an hour, and then things have changed, I'm happy to say, very much since then. I was surprised to learn that epilepsy was a spectrum disorder. Some patients were very, very well controlled and can go on and live a good life, and others were not. Back then, all we talked about were the patients with epilepsy who were doing great and could go on to be Olympic medalists and the such. I learned that epilepsy was really common. 1 in 26 Americans will develop it in their lifetime. I learned that 70% of the patients with epilepsy didn't know the cause, and the economic burden was huge, 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 huge. But the statistic that really stuck with me was this one. There hadn't been much change in the identification of root causes of epilepsy. And you can see that really well here between 1975 and 2014, with the exception of a few additionally identified causes. We really didn't know, nor were we looking, nor was the technology really there to help us. And I'm happy to say that that's changed. But this is really what got me into the scientific field. When Savannah was about 5 years old, I enrolled in college. I spent many years remediating, and after 12 long years, got a PhD in cellular molecular neuroscience. And during my postdoc days, I was working in a genetics lab right at the time the technology to sequence whole exomes had become commercially available. I had worked in a genetics lab as an undergrad, and we were sequencing, on single capillary sequencers, one gene at a time, a couple genes, over a week. And so I came back, 4 years later, and I was like, oh my gosh, what have you guys done? Everything's completely changed. It was very exciting. And during my postdoc, I had the privilege of sequencing Savannah's DNA. And just to cut to the chase, we actually found something. We didn't find any driver genes that were causing her epilepsy that were known genes in the space. But if you looked at the rare variants that were unique to her for what we knew at the time, that were de novo, that were predicted to be pathogenic, we found a number of genes that were in calcium channel genes. And I don't think I have to tell this crowd very much about calcium channel genes and how they play a major role at the synapse, among other places in the brain. I call this crazy mother analysis, and I think at some point, many of you are probably already doing this type of analysis where you actually take all the genes that are predicted to be pathogenic and you group them into pathways in the patient as opposed to just looking for a single driver gene. If you're not doing that yet, you probably should be. But back then, let's see, this was 6-7 years ago, it was not something we were doing standardly. So we found a number of these genes in her, a number of mutations. There were 25 total gene mutations in calcium signaling pathway in her. She has an incredibly high mutation load, and a number of those were in L-type calcium channels. So we immediately made a case for putting her on a drug that modified L-type channels. And we had some really good evidence that at least some of those mutations in L-type channels were gain of function. In addition to that, every time that she was put on calcium supplements, which is pretty common in kids with epilepsy who are on anti-seizure meds, these seizure meds are notorious for leaching calcium from the bone, so they often put kids on anti-seizure meds. And every time she would go on them, she'd end up in the hospital in a coma. So we were able to quickly determine, that she had this negative response to calcium. So we put her on verapamil, an FDA-approved drug for arrhythmias and hypertension, and it began to work immediately. Within 2 weeks, she had a 95% reduction in her seizures, and that has been maintained. She was 18 years old, and she is now 23 years old, and she has less than 20 seizures a month now, down from anywhere between 100 to 300 seizures a month. She doesn't seize every day. When she does seize, it's at night, which makes her a little bit safer from the standpoint of injuries, but not that safe from the standpoint of sudden death. But I think even more life-changing was the number of emergency medicine rescues that we had to do. She stopped going into non-convulsive status epilepticus when she was 18 and hasn't, knock on wood, gone into status since then. So this has been a major life change for Savannah, not having seizures every day. She's been doing really, really well. And here's just a short video of her interacting with her world and her seizure dog, Yukon. She used to sleep all day and could barely talk, and so she's doing really, really well. She's been able to come off about half of her anti-seizures medicines. She's walking, she's talking, she toilets herself. She is still the mental age of about a 7 or 8 year old, but that's up from the 2 to 3 year old that she used to be. So I just want to spend the last 2 minutes here just talking a little bit about epilepsy genetics. It really has changed. I don't have to tell you guys, it was, one gene at a time for many decades. And with the next generation sequencing revolution, we've really seen a huge increase in the number of genes identified in the epilepsies. I'm pretty inclusive when I talk about them. There's more than 20 genes that cause the familial inherited epilepsies. There are more than 300 genes that cause the structural and metabolic syndromes, which can be associated with epilepsy. So things like storage diseases, chromosomal abnormalities. Down's kids, a large percentage of them have seizures. Kids with double cortex or lissencephaly can have horrible seizures. And then, of course, there's the de novo mutations that really have rapidly been identified since SOAP sequencing. And I think this 26 genes is even higher now. It's much higher, where it's de novo single gene mutations that are popping up in these kids. So it's now believed that the majority of the unknown causes of epilepsy are at least in some way related to genetics, and we're beginning to really hammer that out. And that, of course, opens the door, as all of you guys are aware, to precision medicine, this idea, not unlike what happened in a very serendipitous, not that scientific way with my daughter, but doing it in a non-serendipitous, very scientific way, moving forward with patients. And I encourage all of you, if you get a chance, to take this look at this paper by Ann Paduri from 2017 that talks about the genetic epilepsies that exist today that actually have changes in management that can be implemented. Anything from go on the ketogenic diet if you have glucose transporter deficiency disease, to stay off this drug, it will make your liver fail if you have POLG1 mutation. So we're really moving forward. And then in some cases, prognosis is the best we can do. We can say if you have this gene mutation, then you really need to be watching for things like SUDEP or other things that will develop over time in the patients. And we really have started talking, almost all of the genes listed here are associated with LGS. So worst case scenario, some of these children who have SCN1A mutations or TSC1 and 2 mutations will go on to develop LGS, which, remember, is a clinically defined syndrome. It's sort of a final common pathway that ensures that you have a 90% chance of being intellectually disabled and an 80% chance of continuing to have seizures. It's not a pathway anybody wants to go down. But we've started to think about all of these genes in LGS as risk factors for developing this disorder of the secondary network. And what can we do to prevent an SCN1A patient from developing LGS, or a tuberous sclerosis patient from developing LGS, to going into this slow spike and wave. And so we really, when we're talking to people, we're really saying, listen, if you have LGS secondary to SCN1A or SCN2A or POLG1, you want to say that. You want to say, I have LGS secondary to this gene defect or this trauma incident, because many of us in this space, we actually get like services for our children through the schools, speech therapy, physical therapy, by an LGS diagnosis, not by a gene name. And we don't want to abandon a meaningful concept such as LGS. As much as I would love for it to just go away forever, I think we need to keep both names for now: the cause, the etiology, and the electroclinical syndrome, LGS. So, and I know a lot of people won't agree with me on that, but that's okay. So here's a quick list of about 18 genes that we're tracking to, all of these associated with LGS. You guys have seen these: CDKL5, like I said, Down syndromes, FOXG1. This is where reports in the literature of some patients that have developed LGS. And so each of these is risk factors. And this list is twice as long now. It's a diverse group of pathways that are involved. So at some point, somebody, if anyone wants to do that with me, call me, email me. We need to start looking at how the biological mechanisms break down for these LGS genes and if there are any patterns whatsoever. And we need to start moving away from just talking. This is actually how LGS is still presented today, is 70% of them are structural and 30% are unknown. And we really have a big push at the foundation to change this and really start talking about, we think we actually know the cause of LGS in about 95% of cases. And those causes are all risk factors for this horrible, devastating epilepsy. And then, of course, finally, at the foundation, we're here to help. We do have a grants program. So if you have research that you're doing on LGS or any of these genes or any of these precipitating events like malformations or hypoxic ischemia, we would love to fund you. It's a small grants program, but we're working on growing it. We also will help families, send families our way. We have chapters in Mexico, Spain, Italy, Australia, the UK, and I'm Canada. So we're all over the world. And with that, I probably went over my time. I apologize, but thank you for hearing me out. And thank you, Dennis, for having me. I appreciate it.